In our last episode of Let's Go Shorts, we discussed classification and approach to the patient with the disease of obesity. Once a patient feels comfortable talking about their weight, it is very important to obtain a thorough history, do a good physical exam, and think about other disease processes that can be caused by having obesity or make it more challenging to treat this disease. My name is Peter Ammon, and I'm a weight loss specialist in Portland, Maine, and these shorts are being made to help clinicians improve their comfort and confidence in treating obesity. Obesity can be thought of as a disease whereby an unhealthy, excessive accumulation of body fat can contribute to over 200 health problems we see in medical offices every day. The comorbid diseases could be segregated into 3 buckets. The first bucket is sick fat disease, or adiposopathy, medical problems associated with an endocrine or immune response and dysfunction of normal organ and tissue function. These conditions are sometimes related to excess inflammation in the body, dysfunction of hormones, which can lead to elevated blood sugars, cholesterol, blood pressure, metabolic syndrome, fatty liver disease, insulin resistance, type 2 diabetes, gout, early puberty in girls or delayed puberty in boys. Over time, increased inflammation and cell turnover can lead to higher risk of more than 10 kinds of cancer. The second bucket of diseases that can accompany obesity can also be influenced by fat mass disease, the wear and tear over time or compression of tissues that can affect normal anatomy and physiology. Examples in this category include asthma, sleep apnea, GERD, hypertension, intertrigo, and increased stress over time on weight-bearing joints, which can lead to pediatric conditions such as slipped capital femoral epiphyses, blunt disease, scoliosis, and osteoarthritis seen in adults. Patients will often have more joint pain, not only in the weight-bearing joints such as low back, knees, and hips, but due to increased inflammation, patients can have increased pain in their elbows and even fingers. This inflammation can make it more difficult for a patient to be more active or exercise, since pain will often get worse after trying to be more active. The third bucket of diseases that can be related to obesity are the psychological effects of this disease, often influenced by the stigma and bias of others towards the patient with obesity. There's a lot of shame and blame often with patients with obesity, which can lead to isolation from peers, less participation in social activities, increased risk for bullying, increase in loneliness and isolation. There is a reciprocal relationship with depression, in that having depression can increase risk for developing obesity in the future, and vice versa. Having obesity can increase risk of becoming depressed. A history of abuse, neglect, or even poverty or lack of adequate resources can also affect someone's weight. Having obesity can affect a person's quality of life, with one study showing reduced quality of life for people in the highest BMI category as worse than patients with cancer, heart attack, or diabetes, and similar to patients with schizophrenia, heart failure, or kidney failure. When seeing a patient in the office who is interested and willing to talk about obesity, open-ended questions and allowing them to tell their story can be helpful. How long have you struggled with obesity? Did it start in childhood, as a teen, after pregnancies or life stressors? What have you tried in the past to lose weight? Sometimes asking permission to show them the weight curve in the electronic medical record over the past 10 to 15 years, if available, can be helpful for them to tell their story. What are their goals of treatment? What have they heard about patients who have used medications for treatment of obesity or who had weight loss surgery? Have they ever been involved in a formal weight loss program? What other disease processes might they already have or at risk for? Could they have comorbid disease processes, or are they at risk for other diseases that can be associated with obesity? Think about the 3 buckets of diseases we talked about earlier. Have they taken medications in the past that could increase weight? Have they ever tried medications for weight loss? Taking a good social history is important to think about habits that can contribute to weight gain. Does the patient drink a lot of calories or have a sedentary job, lack of adequate sleep, work the 3rd shift, or lack of activity outside of work, or access to a safe place to exercise? What is a typical day for meals or snacks? How often do they have drive-through, takeout, or restaurant foods? Is there a strong family history of obesity and/or diseases that we often see comorbid to obesity, such as diabetes, heart disease, mental health problems? Can they afford healthy foods? Do they live alone or have a good support system or chronic stress? Were there certain food rules growing up, cultural influences, or history of abuse? Once we take a good history, doing a thorough but focused obesity-specific physical exam, and thinking about potential labs and other studies to help identify comorbid conditions is the next step in the work of obesity as a disease process. We will discuss these next steps next episode. What do you think about these Let's Go shorts? Are they helpful for your practice? Entertaining? Too long or too short? We would love to get some feedback, so if you're interested, please contact Dr. Tori Rogers at the email above to give your thoughts. We are offering a $25 Amazon gift card to those who complete a short interview with Dr. Rogers. Thank you.